I'm very pleased to introduce Dr. Andrew Huffer. He's a board-certified vascular neurologist at the Seattle VA, where he is the medical director of the OIG-certified Primary Stroke Center. He completed his medical school and residency at the University of Rochester and a vascular neurology fellowship at Harborview Medical Center at the University of Washington. He divides his time between inpatient general neurology, stroke clinic, telestroke coverage with the VA National Telestroke Program, and resident and medical student education. He's also an investigator with a multi-center research consortium defining the epidemiology of stroke in patients living with HIV/AIDS. He has tremendous expertise to share with us today on advances in stroke treatment and prevention. Welcome, Dr. Huffer.
Well, thank you so much for having me. It's been a few years since I've had the opportunity to speak as part of this lecture series. I'm looking forward to this and getting some good feedback. So without further ado, I have no disclosures to report for the purposes of this talk. And just to go over the outline of what we're going to be talking about today, this was in some ways a little bit of a late addition to what I was going to talk about, in that the 2026 American Stroke Association guidelines on early prevention and treatment of stroke just was published about a month ago. So I felt like this was a great opportunity to share some of the important guidelines that were published in that document. And then for the remainder of the talk, I'm going to kind of highlight a number of management challenges that I've encountered in my practice and questions that seem to come up fairly frequently, especially coming from primary care providers, and how to deal with certain things that may arise after somebody has had a stroke. A lot of these sort of revolve around the area of medication management, and particularly anticoagulation. But also I'll talk at the end a little bit about specifically cerebral amyloid angiopathy as a particularly pertinent issue that affects a lot of patients in the geriatric population in particular. So, as I mentioned, just about a month ago, the AHA and American Stroke Association came out with this guidelines for the early management of patients with acute ischemic stroke. So this is updated every 5 or 6 years or so. This really, as the name suggests, kind of deals more with the very early stages of somebody presenting with a stroke, so may not touch quite as much on longer term management questions, prevention in particular. But I did want to highlight a couple of what I found to be sort of key takeaways from this that might be relevant for more of a general group like this. So number one, just kind of reaffirming the importance of getting every patient who's potentially eligible for an acute treatment treated. So that obviously, the first thing we think about is IV thrombolytics. And so these guidelines kind of just reaffirm the importance of this. And basically, any patient who is presenting within 4.5 hours of the last known well time, who's eligible for IV thrombolytics, should be receiving either tenecteplase at a dose of 0.25 mg per kg, or alteplase, which is sort of the old standby, at a dose of 0.9 mg per kg. These treatment options have been found to be more or less equivalent to each other. If you're not all aware of this, tenecteplase is given as a single one-time bolus, as opposed to alteplase, which is a bolus plus an infusion over an hour. So there's a lot of kind of systematic and procedural advantages to tenecteplase, but I think functionally speaking, they are essentially the same drug, and they have very similar efficacy rates. A corollary to this is that some of the earlier doses for tenecteplase that have been studied, specifically a higher dose of 0.4 milligrams per kilogram, is not recommended due to increased bleeding risk. I would say that a big focus over the past 5 or 6 years has been kind of trying to expand the window of when we can use these really highly effective agents. And so we've been limited to, this early 4.5 hour treatment window for a long time now. But just in the last couple of years, we're starting to see some new trials come out that have tried to push those limits a little bit. So the first of these was basically looking at the subpopulation of people with so-called wake-up strokes, who basically, wake up obviously with stroke symptoms. And traditionally, we haven't really been able to treat those patients because it's really hard to determine the last known well time. And we kind of by default have to use when they went to bed, unless there's like a known time during the night when they got up. And so there's been a couple of trials that have looked at these patients with wake-up strokes and take a select group of them who we can establish that they're within 9 hours from the midpoint of their sleep, or within 4.5 to 9 hours of their last known well time, and really stratify them based on some more advanced imaging techniques, including some MRI and sometimes some perfusion-based CT imaging, to try to find some additional patients who might benefit from IV thrombolytics. So that gets sort of a slightly weaker level of recommendation, but for hospital systems that are set up to do very timely MRI scans, for example, this may be an option that really extends the potential treatment window for a lot of these patients. And I don't really, I'm not going to include this here, but something that was presented at the recent International Stroke Conference earlier this month was actually really pushing this window out to potentially 24 hours, using CT perfusion-based technology to try to select patients who have enough salvageable tissue and a small enough ischemic core that you may want to go after them with IV thrombolytics. So I think in the next several years, we're going to see a lot more in this area. And probably, I would imagine that we're going to see a little bit of a push of this time window when we can potentially offer IV thrombolytics. The other main treatment that we have in the acute setting is endovascular thrombectomy. So this is where we go in with a catheter and try to extract a clot that's causing a large vessel blockage in the brain. And so basically, since this technology or this treatment approach finally established its efficacy in 2015, there was sort of a big rash of papers that came out in 2015 that finally showed that this approach is effective. And not only that, but highly effective. There's been a real push to, expand the pool of patients who are potentially eligible and who might benefit from this sort of therapy. So the guidelines from this year kind of reflect that push. So basically, we know that within 6 hours of last known well, if somebody has a large vessel occlusion, almost across the board, they should be getting a thrombectomy. And I should mention that this is mostly referring to anterior circulation occlusion. So that would be basically the internal carotid artery or the middle cerebral artery primarily that we're talking about here. So, anybody within that 6 hour window should be getting an endovascular thrombectomy, regardless of how big the stroke is, how much early ischemic change there is. The trial after trial has really showed that all of these patients really stand to benefit from this therapy. Not only that, but patients potentially out to 24 hours can also stand to benefit. There was a couple of trials published back in like 2019, 2020 that showed that particularly in the subset of patients with slightly more severe deficits in this extended window, as long as they have some salvageable tissue on perfusion studies, it's worth going after those as well. And I think increasingly we're finding that even patients with larger strokes in that extended time window probably also benefit from an endovascular thrombectomy. So these, high level of evidence recommendations really reflect how much literature has been devoted to this area in the past couple of years. And so this is really the kind of the gold standard of acute stroke treatment, I would say, when people have large vessel occlusions. It's a little bit murkier when it comes to posterior circulation strokes. So mostly we're talking about basilar occlusions here. And I think the challenge there is that number one, there are fewer of them. So it's a subset of patients that it's a little bit harder to study. But the other thing is that it's such a potentially devastating stroke syndrome that I think a lot of times people feel really obligated to go after them, even if they're really far out from their last known well time. And so the guidelines this year kind of reflect that fact. So basically, patients who have pretty severe deficits, and just as a reminder, so people who have basilar artery occlusions potentially can, at the most sort of the worst end of the spectrum, they can be completely locked in. They may completely lose the ability to move almost any muscle just because of the anatomy of the brainstem that's affected. And so, patients who are out to 24 hours or sometimes even more, we might consider doing kind of a life-saving heroic thrombectomy, just because you sort of the consequences of not doing anything are potentially so drastic. What's a little bit less clear still is, this population of patients who have basilar occlusions but are not quite as severely impaired. I would say that the evidence supporting thrombectomy out into an extended window in that group is not quite as clear yet. That being said, I think a lot of people would still recommend going after those just because there's no guarantee that somebody who's looking pretty good right now may not decompensate over the next 24 to 48 hours. So if somebody like this comes in is within 24 hours of last known well, there's a pretty good chance that they're also going to benefit from a thrombectomy, in my opinion. So those are kind of the two, acute interventions that we have to offer for ischemic stroke. A sort of a subset of patients, so patients who have large middle cerebral artery occlusions or terminal internal carotid artery occlusions are often at risk for developing really life-threatening swelling and edema, which can cause herniation under the wrong circumstances. And so this is an area of guidelines that kind of reflects the need for some complicated decision making and kind of goals of care discussions. So when people develop this clinical worsening, usually within 2 to 5 days of when they come in with these large middle cerebral artery territory strokes, the main option that we have, there's some medications that we can give to try to reduce osmolality or increase osmolality rather. But really the definitive treatment is to do a craniectomy where you remove a portion of the skull, open up the dura and allow the brain to temporarily expand outwards instead of pushing downwards and herniating. And so it's been recognized for 10, 15 years now that this is a potentially life-saving procedure. What we are kind of learning more is that, these are patients who are going to be severely disabled from their strokes, in any way you slice it. And so it seems to be that there's a difference in terms of the patient population we're talking about. So in patients who are younger than 60 years old, it's worth considering this type of life-saving intervention, not only because it will be life-saving, but also there's some evidence that it may improve their functional outcome. And, we're not talking about a miraculous recovery most of the time. We're talking about moving somebody from being completely dependent and not able to eat and that sort of thing to maybe being able to walk with some assistance and tolerating a dysphagia diet or something like that. So we're talking about marginal gains, but still, documentable gains. By contrast, patients who are older than 60 years, they still have this mortality benefit. So, you may save their life by doing a craniectomy, but as of now, there's not really much evidence that you're going to meaningfully improve functional outcomes. So this is a really important distinction to make when you're having goals of care conversations with family members after this type of a situation, that yes, we can do this procedure, we can potentially save this person's life, but in all likelihood, it's not going to necessarily translate to a better quality of life or improved functional outcome. So an important thing to recognize. Then this is another issue, kind of transitioning more to kind of inpatient to outpatient. So what do you send patients home from the hospital on? And this is probably something, if you're in primary care or seeing these patients once they leave the hospital, you've probably encountered. So long history of debating exactly what antiplatelet medications we should be using. But there's been a couple of pretty large, well-designed trials over the past 5 to 10 years that have looked at specifically a population of patients who have relatively minor non-cardioembolic strokes. So these are small vessel strokes, or they're atherosclerotic related strokes that do not result in significant impairment. And what the evidence seems to suggest is these patients do better on a dual antiplatelet therapy regimen. So most of the time, that's going to be aspirin plus clopidogrel. Sometimes there's also a study that looked at aspirin plus ticagrelor, which showed similar benefit. It's just that's not one that we see quite as often in practice, I would say. And so if you're seeing a patient with this kind of a stroke, relatively minor non-cardioembolic stroke, for the most part, unless there's some reason not to, they should be getting dual antiplatelet therapies for at least the first 3 weeks after their stroke, after which they should transition to a single antiplatelet therapy. Most of the time, that's going to be aspirin, but in some cases, like let's say they were already taking aspirin when they had this stroke, then after that 3-week dual antiplatelet therapy window, you may decide to transition to clopidogrel monotherapy. So this is not the strongest level of evidence, which is a little surprising given that there's 2 pretty large studies that have showed this. But still, I think that would be a very widely accepted practice in the stroke community. I'm not going to cover that second recommendation there, just because that's not really a medication we utilize all that often. So then kind of shifting gears again, talking about rehabilitation after stroke. This is not, my primary focus, but I thought it was worth pointing out a couple of things. So one is that it used to be that we would recommend SSRIs pretty routinely to help with motor recovery. This was based on some trials that were pretty small trials that were done, in the early 2010s or so, looking at kind of open label trials, looking at SSRIs, and maybe there's a little signal there that SSRIs might help people's motor recovery after a stroke. But subsequent research really hasn't borne that out. And so there's actually a fairly strong recommendation now not to utilize SSRIs just for the purpose of motor recovery. There may still be a very good reason to put somebody on an SSRI for post-stroke depression, but we should not be using that for motor recovery. And then another kind of pretty strong recommendation against a particular type of therapy comes down to early mobilization. So this refers to sort of a model where within 24 hours of somebody coming in with a stroke, you get them up out of bed, working intensively with physical and occupational therapy. And there's actually pretty good evidence to suggest that that does more harm than good. I think the thought behind this is that people in that acute phase after having had a stroke are often very perfusion dependent, meaning that there is an area of their brain that is sort of very susceptible to additional insults. And if you do things that are going to potentially drop blood pressure, or drop their oxygen levels, for example, you're putting more stress on an already stressed system, and you're more likely to cause harm than good. So that's a pretty strong guideline against doing this early mobilization type of rehab. So those are kind of the highlights that I picked out. There's quite a few additional guidelines, obviously, that were published relating to stroke systems of care, pre-hospital notification, mobile stroke units, lots of other areas that have to do with early treatment and prevention strategies. But I thought I'd kind of highlight a few of the ones that really stood out to me that would be most relevant to this group. Um, so I think I'll transition here, and I'm going to basically present a case. So this is a patient that I've followed starting a number of years ago. So this is a 76-year-old guy at the time who came in, had a history of high blood pressure, high cholesterol, tobacco use, no longer smoking though, COPD, who presented with some altered mental status, slurred speech, and left-sided facial droop. So his early stroke evaluation came back looking pretty normal. The non-con head CT looked okay. All of the vessel imaging was pretty unremarkable. He had nice open looking vessels. He had an echocardiogram that showed some diastolic dysfunction, but no specific wall motion abnormalities, a little bit of left atrial enlargement and no PFO. So his MRI, you can see in front of you, there's a couple of representative slices, basically shows kind of some scattered strokes in the right hemisphere, mostly in the right middle cerebral artery distribution. You could maybe argue that the one on the top left could potentially be right near the posterior cerebral artery territory, but I think that certainly all in the right hemisphere. And so this looks like what we would call, an embolic stroke, where a blood clot presumably started somewhere further down and split into several different pieces and ended up affecting a few different areas within the brain. So, I think in this type of a situation when we don't see any evidence of really significant carotid atherosclerotic plaque or middle cerebral artery atherosclerotic plaque, I would be thinking pretty strongly about a cardiac source of clot in this type of a situation. So while he was in the hospital, the telemetry didn't show anything too concerning, and then he subsequently wore a 2-week heart monitor that was negative for atrial fibrillation. One additional kind of detail during the hospitalization was that he did have a fairly elevated BNP on his labs, over 1,000. So this kind of transitions into this kind of a discussion of this topic of what we call ESIS, or embolic stroke of undetermined source. This has become a hot topic over the last 10 years or so, I would say. What we mean by this is essentially a stroke that's non-lacunar, so it's not related to small vessel disease. There's no significant stenosis of any of the large arteries that supply the territory where the stroke occurred. So we define that in a research context as being less than 50% narrowing of any of the vessels supplying that area. We haven't identified a clear cardioembolic source, so that would be things like atrial fibrillation, a left ventricular thrombus, some sort of a valvular vegetation, either infective or non-infective, atrial myxoma, anything along those lines. And then somebody who doesn't have any other known specific causes, so things like arteritis, vasculitis, or dissection, or reversible cerebral vasoconstriction, anything like that. So this is kind of the broad category for these types of strokes would be cryptogenic, meaning that we've done a full workup and we haven't identified a source. ESIS is kind of considered a subcategory under cryptogenic in that not only have we not discovered a source, but it looks like a very embolic type of a stroke. We just haven't figured out where that embolus came from. So some of the potential causes that you'd think about in this situation include occult AFib. So even though, in this particular situation, we got 2 weeks of extended heart monitoring and didn't see AFib, we know that a lot of people may have very infrequent episodes of AFib, and that even short, very rare episodes may be clinically significant. Another category of disease that often gets overlooked, just when we're kind of briefly scrolling through a CT scan, a CT angiogram, we may kind of ignore the aorta, but a lot of people have a fairly significant burden of cholesterol plaque within the aorta, so it's possible that a clot may start there. We also think about paradoxical embolism, so something that a clot that starts on the venous system and then crosses a PFO and then gets, showered to the brain from there. We think about hypercoagulable states like antiphospholipid antibody syndrome, cancer-related hypercoagulability, those sorts of things. And then we also think about unstable atherosclerosis. So an example, like in this patient, if he had, say, like 40% narrowing of his carotid on that right side, but it looked like kind of an unstable plaque with some hemorrhage within it and looked like mostly soft plaque, then I would be thinking more, well, this wasn't greater than 50%, but that still is a plausible place where a clot might have started. And we are increasingly recognizing that it's not necessarily all about the degree of narrowing. It's a lot about plaque characteristics that determines which ones are going to rupture and cause clots to form. So these are all potential causes. I also want to just kind of talk about this concept of atrial cardiopathy. So what do we mean by that? Basically, what we're talking about is either structural or functional changes within the left atrium that results in a prothrombotic condition. So I think the concept here is that AFib may not be the underlying culprit that causes clots to form in some of these types of cardioembolic strokes, but is more of a marker of something that's going wrong with the atrium overall. And so there have been a number of other proposed kind of biomarkers for atrial dysfunction. One would be on echocardiogram, seeing left atrial enlargement. You can also see if somebody happens to get a cardiac MRI, you may see atrial fibrosis. Lab-based marker would include a pro-BNP, which again can suggest kind of increased atrial strain. And then there's an EKG-based marker called the P-wave terminal force velocity, which we look at in lead V1. Basically, it's sort of the downward deflection of the P wave. You can kind of measure the area under the curve. So it's both the amplitude and the duration of this terminal force can give you a clue that the left atrium is enlarged and potentially maybe increased risk of forming clots. The reason this has become a focus is that all of these markers that I mentioned have basically been associated with increased risk of cryptogenic stroke. So I think the proposal is basically that maybe some of these patients who don't have known AFib but have one or more of these other markers could be at equally increased risk of having cardioembolic strokes. And based on that, I think that the question has logically come up is, should we be just empirically anticoagulating some of these patients? And so there have been a number of pretty big randomized studies that have looked at that question over the past 5 to 10 years. The biggest ones you can see here: RESPECT-ESUS, NAVIGATE-ESUS, and ARCADIA. So as you may start to get a sense of, the latter two studies were stopped early. And unfortunately, for all of these studies, basically, rates of recurrent stroke were no different between aspirin versus these anticoagulants. And rates of major bleeding were also non-significantly different, and nor was mortality. So basically, negative studies across the board. Not only does putting somebody empirically on anticoagulation not seem to help, it doesn't really seem to do much for their bleeding risk or their mortality either. So based on these findings, basically, I would say that the current state of the literature is that if you have somebody who has a cardioembolic looking stroke, but you would categorize as ESUS, meaning you don't have a known source, even if you're kind of tempted to, you probably shouldn't put them in anticoagulation because there's really no evidence that it helps. It's any more effective than aspirin. So that's kind of one thing to think about early on. And what does that mean in practice? So generally what that means is we double down on trying to find atrial fibrillation, because we know for sure that if somebody has atrial fibrillation, then there definitely is benefit in putting them on anticoagulation. So as I alluded to earlier, we know a lot of people will have occult atrial fibrillation, and in 2 weeks of monitoring, or certainly a 48-hour Holter monitor, may not nearly be enough to detect that. So this is now an older study from 2014, but the Crystal AF study really looked at patients who'd had a cryptogenic stroke and then had a loop recorder implanted. And they followed them over the course of the loop recorder, which can stay in for up to 3 years. And for anyone who doesn't know, a loop recorder is basically like this little, almost like a USB thumb drive size device that just goes under the skin and the chest and can continuously detect atrial fibrillation and other arrhythmias for up to 3 years. And so what they found was that at 6 months, the group that got the loop recorder had about 9% rate of AFib detection compared to the group that just had their routine post-stroke monitoring. And then if you extend that out even further, so to 12 months, that the rate of AFib detection had increased to about 15%. And at 3 years, it had increased almost to 30%. So about a third of patients within 3 years of having a cryptogenic stroke will go on to be diagnosed with AFib. So this stroke is almost like a little warning sign, or kind of like, a signal that there was something going on there all along. And it just sometimes takes a long time to detect that. Basically, this is kind of a similar study, just using a little bit shorter term monitors, comparing basically a standard 24-hour Holter monitor to a 30-day monitor. And they found a pretty significant difference between the 30-day and the 24-hour monitor. I don't know why their rates were so much higher in this study, but they found that in the 30-day monitor, the rate of AFib detection was 16% versus 3% in the 24-hour monitor. So at any rate, I think there's very good evidence that if you are highly suspicious for a cardiac source of clot, you should probably go to the effort of doing some longer term monitoring. Areas of uncertainty, I would say, within this realm are, what constitutes a significant amount of atrial fibrillation. So there's some people who may just have like 5 or 10 second runs of what looks like AFib, and that's all you see on their 14 or 30-day monitor. And the question is that enough to, commit them to lifelong anticoagulation? I've heard arguments on both sides of this, where, some people will say that if it's less than 30 seconds, it's not significant. I've heard other people, including cardiologists, say that if it's less than 5 minutes of AFib, it's probably not significant. As a stroke neurologist, I would say that if somebody has a cardioembolic looking stroke and has any amount of AFib on their heart monitor, I have a pretty low threshold to just pull the trigger and start them on anticoagulation. Other areas of uncertainty, I would say, other types of atrial tachyarrhythmias, we don't really know how significant those are. There have been some studies that have looked at atrial tachycardia and found a higher association or risk of recurrent stroke. The other thing that's often kind of a puzzle to know what to do about is somebody who has a documented historical history of AFib, like say 10, 15 years ago, but as far as you can tell, they haven't had anything since then. Or somebody who's had like say an aortic valve replacement and has some provoked AFib right after that in the setting of the surgery. Those are situations we think are probably a little bit lower likelihood of continuing to have AFib later on. And so I think with both of those situations, my tendency would be to just get the extended rhythm monitoring and be sure. But I'm always going to have a little bit in the back of my head, is this somebody who I should just be putting on anticoagulation? So it's a little hard to know, I would say. So kind of transitioning to some of the longer term prevention guidelines, the last ones that were published suggested that if you're considering a cardioembolic source, then it's reasonable to get 30 days of monitoring. So depending what type of monitor you have in your system, like at the VA, we have a Zio patches, which run for 2 weeks. So a lot of times I'll do 2 subsequent Zio patches. Some places will have just a 30-day heart monitor up front, that's obviously a little bit more convenient. But I think we should be thinking about doing around 30 days of monitoring for these types of strokes. I would consider longer term monitoring with a loop recorder in a selected group of people. So older patients are much higher likelihood of having AFib, so I would consider that. Potentially, if they have additional biomarkers of atrial cardiopathy, so some of the things I mentioned, like left atrial enlargement or fibrosis, elevated BNP, or some of those EKG changes. If they have very frequent ectopy, particular atrial ectopy or tachycardia on their upfront heart monitoring, if they have a family history of AFib, or if they have recurrent cryptogenic strokes and despite doing all the workup the first time around, you still haven't found anything. These are all people I would consider ordering or referring to cardiology for loop recorder implantation. So I want to get back to our case. So, his initial workup basically didn't show a likely cause. I think he ended up on aspirin long-term. He may have, I can't remember if he was on dual antiplatelet therapy up front or not, but he ended up coming back a year or two later with expressive language deficits and that he had actually developed while on the airplane flying home from an international trip. He kind of went to the emergency department directly from the airport after landing. And once there, he was actually noted to be an AFib with rapid ventricular response, ventricular rate. And he had a repeat MRI that shows the findings on the right, where you see a couple little scattered small strokes, this time on the left side of the brain. Again, looking very embolic. And I think now we have a much more likely source of these strokes. So my next point kind of comes to timing of anticoagulation. So this is some area that has evolved a little bit over the past few years. Earlier evidence, I would say maybe 10 years ago, basically, I would say the idea was that there's a sweet spot and when you initiate anticoagulation after somebody comes in with a stroke related to AFib, where the concern is not starting it too early. So, usually not within the first 4 days after their stroke, but then not wanting to wait too long and potentially risk them having another stroke while you're waiting. And so not waiting more than 14 days. So that 4 to 14 day window kind of being the sweet spot of when to start anticoagulation. Since then, there have been a couple of trials actually that have looked at this issue and a bigger meta-analysis called Catalyst. And while it's not, a slam dunk conclusion, I would say that these 3 trials suggest that you may actually modestly reduce the risk of recurrent stroke if you start anticoagulation before 4 days, compared to people who start beyond 4 days. You can see the risk reduction there. So the rate of recurrent stroke if you start early was 1.7%, whereas the rate of recurrent stroke starting later was 2.6%. So this is not a huge difference, but in relative terms, that's a pretty significant change. And I think on the good news is that starting them before 4 days didn't seem to increase the rates of symptomatic intracranial hemorrhage. That's the big thing that we worry about, obviously. This is kind of that survival curve that you see within the first 30 days, where pretty early on you see a separation of the rates of recurrent strokes of people who start anticoagulation early versus later. I think that you can probably get a little bit more granular about this. And I would say that most people who have a small to moderate sized stroke, it's reasonable to start within that first 4 days. I probably wouldn't start within 24 hours, but between 24 and 96 hours, it's very reasonable to start. If they have a large stroke, then you may want to wait more like 4 days to a week. And then there are some additional features that I would consider to be more high risk that might wait even a little bit longer than that. And so that would be if somebody already has a symptomatic hemorrhagic transformation, meaning they've bled into the area where they had their stroke, if they have uncontrolled blood pressure issues early on, if they have malignant edema, meaning they have a lot of swellings, for example, in a middle cerebral artery stroke, then those are the types of patients I might consider waiting more like 7 to 14 days to start anticoagulation. In the meantime, it's totally fine to put people on usually baby aspirin, even with some of those higher risk features. That's something we routinely do. We also routinely use heparin prophylaxis while these patients are in the hospital. So kind of maybe a little bit more nuanced way of determining when we'll initiate anticoagulation in these presumed AFib-related strokes. So this patient who we're talking about was started on apixaban, I think within the first 4 days, probably based on kind of what we just discussed. Unfortunately, he came back 6 months later with some right-sided numbness. Fortunately, it can mostly resolve by the time he got to the hospital. And he had this, this MRI that shows some additional really tiny strokes on the left side of his brain. So what do we do with this? We asked him whether there's any chance he had missed his apixaban doses leading up to this event, or whether he'd been on any new medications or been sick or anything else might have potentially contributed, and we couldn't really find anything. And so this kind of brings us to this question of what do we do about recurrent strokes in people who have AFib and are already on an anticoagulant, so-called anticoagulation failure. So the first things you should do, like I mentioned, would be assess for medication adherence. That's usually probably the number one reason why you may have these breakthrough strokes. The other thing you want to do is make sure that somebody's appropriately dosed. So most of these medications have a single dosing schedule, but for example, apixaban has a lower dose schedule for people who have impaired renal function or are older or have low body weight. So just making sure that they're on the appropriate dose that they should be on, and then looking really closely through the rest of their medications to make sure they're not on anything that affects the metabolism of their anticoagulant. So if you rule out all those things, then the question is, do you switch them to warfarin? Do you put them on a different DOAC? Do you add an antiplatelet in addition to the anticoagulant? These are kind of all relevant questions that I get fairly often, I would say. And while I would say that we don't have any really high quality prospective data to support our decision making on this, there's a pretty big retrospective study that was published a couple years ago, looking at 46,000 patients who had this very situation where, they developed recurrent stroke, developed recurrent stroke on anticoagulation. And one important thing to point out that out of these 46,000 patients, about 3,000 of them developed recurrent stroke. So the annual risk of stroke in this patient population on anticoagulants is not very high. So anticoagulants are very, very effective at reducing people's stroke risk. But if they do have a breakthrough stroke, they kind of separated these patients out into those who switched to warfarin, switched to a different direct oral anticoagulant, or had aspirin or another antiplatelet agent added to their regimen. And unfortunately, what it turned out was that switching doesn't seem to be the right approach, and if anything was actually quite harmful. It seemed to result in more recurrent strokes. So people who got switched to warfarin had almost a twofold increase in the number and their rates of recurrent strokes. It wasn't quite so bad with switching to a different direct oral anticoagulant. And there was really no change adding antiplatelets to the anticoagulant. So it doesn't appear that making a change in medication is probably the right approach in these patients who have breakthrough strokes. One thing that they found, as you might expect, is that things like diabetes, large artery disease, and then taking other enzyme-inducing agents were fairly important predictors of who was likely to have a breakthrough stroke on an anticoagulant. So that kind of makes sense. So if we're not supposed to change medications, then what do we do? And that brings us to this idea of maybe using left atrial appendage closure. So if you're not familiar with this, so the left atrial appendage is basically this little vestigial structure that hangs off of the left atrium. Doesn't have any known functional significance, but is an area where blood can basically kind of collect and pool. And in about 90% of cases, people who have AFib and a stroke, that actually is where we find the clot forming. So for a while now, there's been this recognition that possibly closing off access to the left atrial appendage might be a viable strategy to help reduce the risk of having strokes in people with AFib, especially if they can't be on anticoagulants for some reason. But in this particular situation where somebody is on an anticoagulant but then has a stroke subsequently, there's been some interest and actually several studies published, not huge studies, but kind of pretty suggestive over the last couple of years that have tried putting in these left atrial appendage occluders. And what they found that at least over a 2-year follow-up period, it does seem to fairly significantly reduce the rate of recurrent stroke. So, for example, basically the rate of recurrence in patients who got the left atrial appendage closure was 2 per 100 patient years versus almost 8 per 100 patient years in the group that didn't get left atrial appendage closure. So that seems like a pretty promising therapy. I would say that it's, not it's not like established practice across the board by any means, but I think it's something that you may see a little bit more of in the coming years. So, getting back to our case, this guy's had some bad luck. Later on, this guy did not end up having a left atrial appendage occluder, but he was continued on anticoagulation. And so he presented to an outside hospital with headache and left arm numbness. And on imaging, there are a couple things kind of jumped out. So one was that he'd had a small hemorrhage in his right parietal temporal area. But not only that, we see these other areas in the middle slide here where there's this little black dot on the left side. This is sort of, we interpret to be a small microhemorrhage from probably chronic. And then higher up on the right side, we see these sort of black squiggly line, which is basically represents old blood products within the sulcus of the brain. And so we interpret this to mean that at some point in the past, he may have had a subarachnoid hemorrhage in this area. Another term you may see for this is superficial siderosis. So when we see this constellation of findings where there's a larger bleed, there's some areas of much smaller, older bleeds, and then we see the superficial siderosis, this makes us think pretty strongly for a condition called cerebral amyloid angiopathy. So this is a condition that's really relevant for a geriatric population. Basically, what happens is you get deposition of these abnormal amyloid beta peptides that deposit in the vessel walls of these small and medium vessels within the brain, sometimes around the lepta meninges, but also towards the periphery of the brain. And most of the time it's sporadic. We don't really have a good explanation for why it occurs. Very rarely there may be genetic forms of this that are autosomal dominant and tend to present earlier in life. We also know that some of the same genes that predispose people towards Alzheimer's disease also may predispose people towards cerebral amyloid, specifically ApoE4. But also ApoE2 in the case of cerebral amyloid. Both of these seem to confer vulnerability to developing cerebral amyloid angiopathy. And this condition basically can present in a number of ways, one of which could just be asymptomatic microbleeds. So somebody may get an MRI for whatever reason, and we see these little hemorrhages. They can present with symptomatic larger bleeds. And then, like I mentioned, they can also present with subarachnoid hemorrhages, or in a chronic form, we see that as superficial siderosis. In some cases, people can also have these transient neurological episodes that can really mimic either a seizure or a TIA. We call them amyloid spells, colloquially. And these are usually fairly brief episodes of some sort of a focal neurologic deficit that resolves spontaneously, and you don't end up seeing strokes or bleeds on imaging. Another way that it can present much less commonly is what's called cerebral amyloid angiopathy related inflammation. So this is usually sort of it can almost mimic like a vasculitis type of a presentation where people will develop progressive cognitive changes, sometimes focal deficits. And when you get imaging, you'll see lots of white matter changes, often clustered in areas where there's a lot of little microbleeds as well. And the hypothesis is it's an immune reaction against some component of the amyloid that's been deposited in these blood vessels. And we often treat this with corticosteroids or other immunosuppression. So big kind of management strategy in cerebral amyloid, I think the main thing is trying to avoid antithrombotic exposure. So we know that, for example, being on warfarin when you have cerebral amyloid increases your risk of bleeding about 7 to 10-fold. Direct oral anticoagulants are not quite as risky, but still increase your risk. And then being on an antiplatelet agent like aspirin also may increase your risk slightly, although the evidence behind that is not quite as clear cut, I would say. So it's often a conundrum what to do with these patients, particularly if they have compelling reasons to be on anticoagulation, for example. And so somebody who has a mechanical heart valve or has life-threatening thrombosis like a pulmonary embolism or critical limb ischemia, or has like cancer-related hypercoagulability, you may have no choice but to keep them on anticoagulation and accept the increased bleeding risk. But if at all possible, you want to think about whether you can reduce their exposure. And so in the realm of atrial fibrillation, we often think about left atrial appendage occluder replacement for these patients for exactly that reason. And the bottom line is that if you send somebody to have a left atrial appendage closure, they do need to be on anticoagulation, but it's usually a short-term thing. So 4 to 6 weeks or so. And then after that, a lot of times they'll end up being on maybe dual antiplatelets for out to 6 months. But I think you'll see different practices amongst different cardiologists there. And if there's really compelling reasons to just put somebody on dual antiplatelet therapy up front, sometimes you can convince the cardiologist to do that. So that would be sort of our preferred approach if somebody has AFib, is on an anticoagulant, and then is found to have cerebral amyloid, like in this case, we would refer them to cardiology to consider left atrial appendage closure. So that's exactly what we did with this patient. He ended up having a successful left atrial appendage occluder. And like I said, remained on apixaban for 6 weeks and then switched to dual antiplatelet therapy. And then eventually just aspirin monotherapy is usually the longer term antithrombotic approach. So this guy has had quite a saga, kind of highlighting a lot of the kind of management challenges that I get questions about very frequently in my practice. So just to kind of summarize things, some of the take-home points from this talk. So number one, patients should be rapidly assessed for early either thrombolysis or endovascular therapy after presenting with stroke symptoms. A diagnosis of ESIS or embolic stroke of undetermined source should trigger a much deeper diagnostic workup for things like occult AFib and other etiologies, but patients should not be empirically treated with anticoagulation. In patients with AFib, you consider early initiation of a direct oral anticoagulant unless they have some high-risk feature. Consider a referral for left atrial appendage occluder if a patient develops either recurrent stroke despite appropriate anticoagulation, or if they are subsequently diagnosed with cerebral amyloid angiopathy. That would be another really appropriate indication for left atrial appendage occluder. So that was kind of my whirlwind tour through stroke prevention in management issues. I'm obviously more than happy to answer any questions that you guys might have. Barbara, I think you're muted.
Sorry. Sharon said that she valued the new guidelines with expanded eligibility, and but mentioned what is painful is the many patients previously deemed ineligible for older age or waking stroke, stroke on waking. Did
Yeah.
the clinical trials to expand eligibility include a control group, and were studies stopped early for demonstrated benefit?
They definitely did include a control group. The trial, I think the pivotal one that I'm thinking about is called the Wake Up trial. I don't believe it was stopped early. I might be mistaken about that, but yeah, that I mean that is often a challenge, and I would say that even um, now that we have recognition that this is an option for some people, unfortunately, there's a lot of people who may not be able to appreciate that benefit just because of the hospital system that they present to may not have access to rapid MRI, for example. So some of these screening tools may not be a possibility. And that kind of highlights another one of the guidelines that I didn't really talk about, but kind of systems of care. So having really good EMS triage algorithms to take people to comprehensive stroke centers, especially if there's any concern for a large vessel occlusion type of an event where they're most likely to be able to get treated.
Mm-hmm. And we actually have participants, attendees from across the Pacific Northwest, many in rural areas, so it's tough to get them to those stroke
Yeah.
centers quickly. Yeah. But I really appreciated the recent guidelines as well, and including the research that supports that. And I think you did a nice job of addressing questions that come into you from primary care. I liked getting more information about left atrial appendage occlusion. Um, that was actually somewhat new for me. I'm an old coronary care nurse, but um, so great, great research. I'm still waiting for other questions to come in. So I'm going to pose a question to the attendees to encourage you to think about what questions come up when you interact with older adults regarding stroke prevention or post stroke. And please feel free to let us know your setting or your disciplinary role when these questions are coming into you. What kinds of questions, would you love to be able to have somebody with Dr. Huffer's expertise standing right there to pose it over to? Thoughts? To what extent does the post-stroke care vary by region? Are there regional differences in your experience working with um, folks post-stroke?
Um, in terms of secondary prevention aspects, I think it tends to be fairly uniform. You'll see small differences in terms of like, so one that kind of comes to mind is some hospitals are really familiar with using like ticagrelor instead of clopidogrel as their second antiplatelet agent. And I would say that hospitals where the stroke system is led by like interventionalists, they tend to use that a lot more because that's I think been very widely accepted medication, particularly like in the cardiology world, but also
Mhm.
in interventional radiology world with stenting and things like that for a lot longer. So they may just be more familiar with that medicine.
Mhm.
Um, Other than that, though, I mean, I think that ultimately the guidelines for secondary stroke prevention are pretty straightforward, and and pretty easy for people to follow in a uniform way. I would say that probably stroke rehab may look a lot different depending on where you are coming from.
Mhm.
Having like acute intensive inpatient rehab options may not be quite as available in some rural settings, um, or having just the follow-up rehab for that matter in through communities, it can be a challenge depending on where, like, we see a lot of patients from the Olympic Peninsula and find, even when we try to go through community care referrals for physical and occupational therapy, it can sometimes be really challenging to find people who are close enough to where our patients live to accomplish that.
Yeah, I could see that. Kaylin said she's a pharmacist in Geriatric and wonders about specific blood pressure goals for patients' status post stroke.
Yeah. So the general guidelines are less than, are you talking about acute management or long term?
I'm
Because that's,
not quite sure here.
yeah. Okay.
Long
So
term.
long term for almost everybody, it's going to be the typical below 130 over 80. There may be some exceptions to that in practice. So, for example, somebody who has, um, like really high grade stenosis of one of their large arteries, either carotid or intracranial artery, who's kind of perfusion dependent, particularly early on, I will often allow their blood pressure to be a little bit on the higher side, maybe up to 145, even 150, with the goal of gradually getting them down more to normotensive range over the course of weeks to months. Um, typically our acute management after a stroke is permissive hypertension for at least a day or two, kind of let their blood pressure do what it's going to do unless it gets above like 220 systolic. And then we'll gradually bring them back more to a normotensive range while they're in the hospital. But there are some patients who you try to do that and their symptoms get worse every time. And you sort of have to just take a more longer term approach to that gradual reduction, particularly people who may have been undertreated for hypertension for many, many years, and they're kind of residing above their normal cerebral autoregulation curve anyway. And so if you drop it too much, you're just going to drop perfusion to the brain more than you want to.
Oh, interesting. Yeah, I could see that. Thanks. Sinyis, Wang mentioned from primary care providers' perspective, what is your recommendation on prevention of stroke of older adults and optimizing health outcomes? You've said a little bit about that, but do you want to add anything more?
Um, yeah, I mean,
If you don't mind me chiming in, I'm thinking when I think older adults, the other question that was occurring to me was addressing issues of comorbidities.
yeah, yeah. Um, yeah, I mean that's a challenging question. I mean, I think we all have all sort of like the guideline based recommendations for medication strategies, but also you have to think about um, other things that impact people's stroke risk as well. And so, I think sedentary lifestyle is a bigger challenge to overcome in a lot of older individuals, especially after having had a stroke. Um, we focus on sleep hygiene issues, and then I didn't really talk about this at all, but there's a whole literature on screening and treating obstructive sleep apnea after somebody's had a stroke. um, so there's a lot of elements to it, obviously, and of course that rarely are in a geriatric population is this the only problem that you're encountering. So you kind of have to balance it against a lot of their other medical comorbidities, as you said.
And Sue mentions today, after the U.S. Pointer study, being intrigued by the relationship now of brain health to cardiac health. And
Yeah.
this patient has a complicated history. However, um, hopeful she's hopeful our young adults follow recommendations now related to risk reduction, like diet and exercise and blood pressure management, sleep and physical exercise. We
Yeah.
now know, she comments, what's good for the brain is good for the heart. Don't know if you wanted to say anything more about
Yeah.
that. It's a
And I
good
think
comment.
the next question relates to these cardiac brain issues
Yep.
too, about whether it's a two-way relationship. It definitely is. I think it's not uncommon that we see people come in with acute strokes who have troponin elevations and even T-wave inversions and things like that. So demand-mediated cardiac ischemia is quite common, especially after bigger strokes. So it's absolutely a two-way street. Um, I think neurologists would say that the brain is the more important of the two, and cardiologists would disagree. But yeah, I mean, the good news, I guess, if you want to look at it that way, is that a lot of our patients do have premorbid coronary issues, and a lot of times they're already on the same types of secondary prevention that we would institute anyway.
Hmm.
So that's I guess, both a good thing and a bad thing, depending how you look at it. I mean, it leaves less to intervene upon, but at least you're kind of working on the two systems simultaneously when you make any changes.
Yeah. And just wanted to mention that the that other question about heart issues causing stroke issues is coming from a respite worker who I'm sure is seeing
Yeah,
those considerations quite a bit.
yeah, definitely. I'm trying to think if I've seen an example in a younger person where that's been the case. Uh, nothing immediately comes to mind, but yeah, I think absolutely you can see heart issues secondary to a big stroke in
Mm-hmm.
even in younger people.
Mm-hmm. Other questions, folks? This is really just a lot of new information, so I really appreciate it. Um, and you're going to be getting a lecture next week on medications from Dr. Rachel Fireball from School of Pharmacy. So stay tuned for that. And thank you so much, Dr. Huffer, for all of this information. Oh, I see one more question coming in here. Um, uh, oh, it's not specifically. Uh, it's talking about just historically thrombolytics, um, related, just a question about the use of thrombolytics related to the age and the timing of symptom onset. I don't know if there's anything more you want to say about that.
Yeah, I guess I would say that with these wake up strokes specifically, I think people older than 80 were excluded from that study.
Mm-hmm.
So it's not as clear that real geriatric patients are benefit equally from that sort of an extended window treatment. Hopefully, some of these newer trials that are coming out will include some people at that higher end of the age spectrum, and we'll know more about that. But um, I would be a little hesitant to offer that to somebody who's in their sort of late 80s, 90s, certainly.
Mm-hmm. And Cheryl is reflecting back on that issue of stroke in a younger person, and just mentioned that her mother had a stroke at 28 and passed away
Mm.
at 50 from heart disease, and
Oh,
whether
well.
that could have had something to do with the stroke. It's hard to
Uh,
say at this point.
it could be. I mean, yeah, the other thing that I guess this wasn't the focus of today's talk, but young people who have strokes, uh, congenital heart issues are really overrepresented in terms of potential stroke causes in that group. So I think there's definitely a potential correlation there.
Mm. Okay, well, thank you very much. Really appreciate it. And we will see all of you next week for our ninth lecture. And have a very good weekend, everyone.
Thank you.
Thanks, Dr. Huffer. Really, thank you so much.